or whatever you need. And I'll move on to the next slide for you, okay?
Thank you so much. I appreciate
Yeah.
it. Well, it's so good to be here with folks today. I'm looking forward to talking to you about weight stigma and some ways to enhance your weight inclusive care. I do want to mention that, this topic could be somewhat sensitive for folks. It could, everyone's kind of in a different place of their journey in understanding and exploring weight stigma just in general, but also how that impacts them personally. So I want folks to kind of just know that we're all on a different part of this journey. We all have to start somewhere. So I do acknowledge that there's, folks that this might be pretty new information, and for some folks, they might be further along in their process. And I encourage folks to kind of do some introspection and let themselves go to a vulnerable place when necessary. Next slide, please. I want to start with, I'm not going to call on anyone, don't worry, but I want some people to just unfiltered kind of just see what thoughts pop in their mind when they see this image of this woman. Non-censored, just initial thoughts. Next slide.
Don't be shy.
And then now do the same for this image. And, I'm curious if there are any folks that are willing to share about their experience of initial unfiltered thoughts related to these images. And no pressure if folks don't want to go there. And if you feel more comfortable, I'm curious if you think that these two women would navigate the world in the same way.
I can try and break the ice a little bit for everyone. I could imagine that the first woman would have a harder time in medical settings and workplace settings with being appreciated for who she is, and she might be noticed especially because of her size.
Absolutely. Yeah, like a whole different set of assumptions, even if these two women live the exact same lives. Yeah, absolutely. Yeah, thanks for mentioning that piece. Next slide. I think as part of the process of having really good weight inclusive care and doing the best we can for our patients, our research participants, we do need to consider our own thoughts and feelings in relationship to our bodies, to others' bodies, to shape, size. We all do have a relationship there. And I wonder if folks can maybe just spend like 2 minutes just maybe jotting down either on the notes app on your phone or on a piece of paper, just kind of like free association of where you're at with your own thoughts and feelings regarding weight, body size, and shape. All right. Is anyone willing to share some things that they reflected on?
Sherry? I can say something. I was thinking a little bit about how um, uh, the way I might think about myself often is influenced by how much screen time I have at the
Yeah.
moment. And I really was thinking like, oh, that like you don't actually get to, I would say media is not very size inclusive, right?
Mhm.
And so you don't really get to see a lot of people of different shapes and sizes and a lot of the media that we consume. And as I'm getting older, I'm more aware of like the influence that that has on how I feel about myself or how I might feel about myself in that 15 minutes I'm watching that clip.
Absolutely. That's such a great point. I'm glad you mentioned that piece. And I think what's so important when we're thinking about weight stigma and weight bias is it's really all around us. It's something that is part of our culture and reinforced by things like what we're viewing online, and by, our medical systems, our loved ones. It's really everywhere. I also see that Abby wrote in the comments, like noticing being harder on oneself than on others, and that maybe we could be some of the biggest perpetrators of weight stigma towards ourselves. Yeah, thanks for sharing that. Anyone else?
I think we notice, it just makes you think about a lot of the assumptions you make about health, and that, we just get kind of pummeled with popular culture that only a certain body size can be healthy, whereas another one is going to be inherently unhealthy, instead of looking at data that shows that people can be healthy, very robustly healthy at any size.
Yeah, absolutely. Yes. And I think a lot of our medical systems perpetuate that of the idea of like higher weight, more health problems
Right,
when everybody's health is so complex and it's not so simple and
right.
connected like that.
Yeah.
Yeah, absolutely. Yeah, thanks so much, folks, for being willing to share a little bit about where you're at with this and things you notice about this, because, this is really an area where we don't spend as much time focused here, yet it's impacting us constantly. And what impacts us impacts our patients, and our patients are being impacted in all areas of their life. So it is really, it's a scientific journey, but it's also a personal journey. So I encourage people to continue on, kind of interrogating where they're at with this, and working on their own biases that are really normal in part of this culture. Next slide, please. I promise if you do have biases, you are absolutely not alone. This is from the implicit attitude test. There's a weight version of this. If folks haven't taken that before, I encourage you to take it. So measuring those implicit negative attitudes. And most people that take this have some moderate or strong preference for thin people over fat folks. So we do see that this plays out kind of on a global scale. So it's not something that, anybody that holds biases is bad or wrong, but just part of the process. We all kind of grow up in this kind of culture where it's in every realm and very common. So don't be too hard on yourself. It's just, very natural, and, we can move forward and grow. Next slide. So kind of have a note just on terminology. Folks might have already done this shift, but maybe some folks haven't. So I just want to make sure we're on the same page. There's, a lot of movement to shift over away from what have been identified as stigmatizing terms from those with lived experience with higher weight, and medicalized terms like obese, overweight. Those sorts of terms are not super helpful because they're based on the BMI. They don't tell us a lot, and folks could find them pretty stigmatizing, along with those euphemisms like big bone, more to love. People with lived experience really endorse those terms as being problematic for them, whereas other terms like more neutral, just descriptive terms like higher weight, larger bodied, those tend to be more frequently endorsed. So those are the terms that I'll use because I'll often be referring to a group of people. But if you're working individually with someone, you can always ask them what their preferred term is and defer to them. And some folks have reclaimed the term fat, seeing it as just a neutral descriptor, but not all folks feel comfortable with that term. So I'm going to just stick to larger body or higher weight throughout this talk. And even APA is starting to recommend that we shift those terms to be more inclusive. So I think it's just a really good early step is to change your language if you haven't already. Obviously, language is really powerful. And ultimately, switching our language is kind of challenging. So it might be good to practice, get coffee with a colleague or a friend and just practice using the terms you're not used to so that they flow really naturally and comfortably. Next slide. I'm also viewing weight stigma, body size as part of cultural competence. Like the idea that we should know which groups are receiving more privileged and which are receiving more challenges related to simply their identities. So it's good for us to kind of understand our patients' lived experiences and knowing that body size is part of our identities and part of our cultural selves and shapes how we go about the world. Next slide. I found this really great wheel of privilege that I hadn't seen. Most wheels of privilege, if folks have seen these, don't tend to include body size, despite it being a really important part of identity. So I loved that this one actually did include body size with, slimmer, muscular people having the most power in society, whereas like particularly underweight or very thin folks, straight size folks, smaller and mid-fat folks having like in between power, and then as weight goes up, having less power and being more marginalized. Next slide. So I'm curious from folks if they were trained in body size and like that being a component of multicultural competence, specifically in your graduate program. Seeing a lot of no's. Yeah, maybe some folks. Yeah. Unfortunately, it's an area that we tend to not include as part of multicultural competence. Like I went to a doctoral program that was very, very grounded in social justice to inform our science and practice, yet we didn't talk about body size once throughout the entire program. So, I really am hoping that as a field and allied fields that we can start to kind of shift and see this as just part and parcel to good multicultural competence. Next slide, please. So, most folks with higher weight, when they navigate the world, they're seen first for their weight, and including in healthcare settings, like the idea of like you're going in because you have the flu or you have some sort of injury that has nothing to do with your weight, yet your health concern might be ignored and you're told, well, actually, maybe you should just lose weight. This is a really, really common experience for people with higher weight when they go to medical settings. Next slide. And what that is weight stigma, right? Weight stigma is really systemic in that it can be just in the fabric of society, but it also could play out in our day-to-day interactions with our healthcare providers, family, friends, like, strangers just going about the day, where you're receiving these really clear attitudes that are negative about one's body size and making beliefs about who you are as a person from body size. Like a lot of stereotypes of like no willpower, you must be unhealthy, you must be lazy. So all of those sorts of things are weight stigma. Next slide, please. Unfortunately, weight stigma is much more common than people tend to realize. Studies have found it to be the third most common form of discrimination. And if you have other marginalized identities, you're even more likely to experience discrimination related to weight. It's kind of known as like a very widely acceptable form of overt discrimination, and it's often even encouraged by healthcare providers. I just saw a patient last night who told me that when she went to see a lipidemiologist in town, because she was having severe heart issues from overexercise from her eating disorder, because she's higher weight, while she was describing to him how much she works out to the point where she's almost ended up in the hospital and has these cardiovascular issues, he kept on saying good work every time she would say, like, now I'm working out 4 hours a day, and I passed out on the top of the mountain, and he's saying good job, like, over and over again, right? So it's something that is just simply encouraged even by our medical fields, and it's the top reason for bullying among youth. Next slide. Thank you. This is a really awful billboard campaign that was put forth in Georgia. It was called Stop Sugarcoating It, Georgia. And the idea is kind of like to tough love people into smaller bodies, as if that would then impact their health in a positive way. And I always think about like how awful that must be for the kids that are in public transit or in their family car, and they look up and they see this billboard depicting kids of their size in this way. So it's really not surprising to me that kids as young as 3 have been found to exhibit anti-fat attitudes. Next slide, please. Thank you. It's also not surprising to me that people internalize weight stigma, just like people might internalize racism or internalize homophobia and believe that they're the problem and that they're not worthy or they're not lovable because of their identity. We see this all the time with weight stigma. Interesting with weight stigma is that even people without higher weight can internalize weight stigma, because there's always the threat that maybe they'll recover from their eating disorder into a larger body, or they know that if they were to have weight gain occur, that they're going to experience life really differently. So people really commonly internalize these messages. Next slide, please. If folks are familiar with this area at all, they might know that weight stigma is associated with an array of adverse health outcomes. This is just kind of a sampling, but there are many, many more. Of course, disordered eating, eating disorders, body dissatisfaction, those ones I think are really intuitive and obvious that those would be associated with weight stigma. But also suicidal ideation, substance use, pretty much most mental health conditions, so really, really relevant to the field of mental health, but also quite relevant to the field of physical health. I always worry about the idea of weight stigma being associated with avoiding healthcare, and it just makes so much sense. If every time you go to the doctor, you're ignored for your health problem that you came for, and you're just shamed and told you need to lose weight, or worse, then you might not go back. Why would you go back? Yet going to your healthcare appointments can be really great predictors of positive health. So that's a particularly rough outcome that I worry about a lot. I also worry about, like the idea that exercise might be avoided. People might actually experience cortisol increases that sustain over time, cardiovascular issues. There's a lot of adverse health outcomes. I do have weight gain on here as associated with weight stigma, but I just want to be clear that I'm not implying that weight gain is a negative outcome, but it's one that people aren't necessarily targeting whenever they're perpetuating weight stigma. Next slide, please. Weight stigma is also associated with adverse social and academic outcomes. So for example, for kids, we know that kids that have experienced weight stigma have fewer friends, more likely to be bullied and rejected, even delaying when they first have a first romantic relationship. They also have worse academic outcomes. What I think is really interesting about this body of research is that when higher weight kids are in school districts that there are plenty of higher weight kids, there's not a lot of weight stigma, they don't actually have these adverse academic outcomes anymore. This worse academic outcomes is really common in school districts where there's not a lot of higher weight kids and there's a lot of weight stigma against higher weight. And I just want to clarify and just kind of like accentuate the idea that it's not weight that's associated with these poor outcomes, but it's weight stigma that's associated with these poor outcomes. Kind of like it's not race that's associated with adverse outcomes, but racism. Next slide. And, a lot of times, when I talk to people about weight stigma, especially people in the healthcare field. People raise their hand and say like, wait, but we need to care about health. What about health? This is really important. Are you saying we shouldn't care about health? And I'm saying, absolutely not. That's not what I'm saying. But what I am saying is our understanding of the link between weight and health is much more complex than we think. So I want to talk a little bit about what the weight science tells us. Next slide, please. One important thing is that this link between weight and health is really complex. It's not that well understood. Most people that are encouraging weight loss don't know the weight science very well. But there are a lot of components of weight science that are troubling, that should give us some pause. So one is that even if weight loss were to be a useful thing, which jury's still out on that, it's not even maintained by most, right? Like weight loss is not effective. The vast majority of people, some studies as high as 95% of people gain the weight back, and then are at higher weight than what they started. We also don't have a lot of long-term data about weight loss. So even studies that are finding that their regimen, like I think about like the GLP-1 inhibitors, they're finding some modest level of weight loss, but we don't know what's happening long-term. Not just around whether or not it sustains, but are there any adverse implications of that weight loss? Another issue is that many of the studies that cite why they're trying to reduce weight among their participants, they note that it's for health reasons, yet they don't actually study any health outcomes. So a lot of the weight science is looking at weight as the outcome, but not telling us whether or not that relates to any health changes. And then finally, an issue with weight science that I get really, really concerned about is whether or not we are controlling for confounding variables that might explain a relationship between weight and health. So I'm going to get into some specific examples in a little bit. Next slide, please. In terms of weight science, it's so common for the literature to find that there either isn't a link between weight and health, or that people in the overweight BMI category have better health outcomes than those in the normal BMI category. I say that with quotes, of course. That researchers have termed this phrase the obesity paradox. So basically they're noting that, oh my gosh, this is not what we were expecting. We were expecting to find higher weight, worse health. That research didn't find that. So now we're going to call that a paradoxical finding, rather than just kind of owning and saying, hey, this weight health relationship is super complicated. There are some studies that have found that particular classes of obesity as rated by BMI, that there is a increase in mortality, but that increase is so modest, and we don't know if confounding variables would change that increase. So for example, those studies are not controlling for experiencing weight stigma, for example. There are many other areas that better predict health. Often those are systemic level issues like access to clean air and clean water and access to food, reducing food insecurity. Those things are much more impactful. Yet we do, have a multi-billion-dollar weight loss industry despite these findings. We also find that for certain health conditions or certain situations, higher weight is a more protective category than lower weight. So for example, you're more likely to survive a stay in the ICU if you're higher weight. Yet the healthcare field is not saying like, hey, people should gain a little bit of weight. You're going to be more likely to survive certain health conditions, right? We talk about it in a very black and white way. Next slide. This is just one example of many I found in the literature of why it's so important to control for confounds when looking at the association between weight and health. This was a study that looked at the relationship between weight and dying from the flu. And what the study found was that higher weight was associated with being more likely to die from the flu. But then these researchers smartly thought to themselves, what about some of the other variables that might be at play here? should we control for those? And what do we find in relation to weight and dying from the flu? Well, they controlled for early antiviral treatments. So when people received an early antiviral, and they found that the relationship between weight and dying from the flu was no longer present when you controlled for when people received early antiviral treatment. So really what's likely happening is either higher weight people are delaying going in to receive healthcare, likely because of experiencing stigma, and or when they are going, their providers are more fixated on weight versus what they're coming for and are missing opportunities to provide them essential treatments like an early antiviral treatment. And then these higher weight folks are more likely to die from the flu. So we do know that weight stigma, does put higher weight people at a higher risk of dying prematurely from lack of healthcare access. Next slide, please. So that was mostly a primer to kind of get people up to speed. I know people have different backgrounds in terms of how much knowledge they have in the area, but I wanted to get people up to speed on, why we should care about weight stigma, its association with adverse health outcomes, and how complex weight science is. But now I'm going to shift gears a little bit now that we have that mutual understanding. We're going to shift to what might this look like in mental health settings, but I think this also translates to related settings, just general healthcare settings as well. So I'm curious to hear from you all, like, where do you see weight stigma show up?
I'll break the ice a little bit and say that as an eating disorder treatment program or part of some of our roles as part of our eating disorder program, and we can see weight stigma show up in our admissions process at time to see who's eligible for inpatient eating disorder treatment. So that's one of the examples I can think of.
Absolutely. No, that's a great example. I remember before grad school when I was at a higher level of care facility, when I would call insurance companies to try to get higher weight folks into our binge eating disorder IOP, they would often give a lot of pushback of like, this person sounds like they need to be referred to weight management, not to an eating disorder treatment. And I'd have to like really fight with them on it. Did I see a hand? Sorry, I'm really bad at using Teams, so I can't see.
Hi, yes. Can you hear me?
Yes.
Okay. So I've got a mixed bag in terms of caseload. I have both folks who are diagnosed with an eating disorder. Others are having some patterns of disordered eating. But outside of those parameters, I've seen it a lot in illness anxiety. And, it really can shift a person from, a balanced way of thinking about body image and themselves to going to like really extreme places, and then they'll start getting really anxious and really starting like showing symptoms of an eating disorder with all the anxieties around illness that are associated with obesity. And I think that's a little tricky because there are some fundamental facts about obesity and how it's related to cholesterol. And so I'm just relaying to you some of the things that are coming through the grapevine from my clients. And I think as the practitioner, it's sort of like, where do we land here, right? What data do we trust in order to instill a healthier image? What data do we trust in order to help them see this as a place of balance, as opposed to all of these really like biased perceptions and the dysmorphia that comes from what is sounding like some illness anxiety because of it. And there's so much information out there. It's just, you just don't know, so.
Yeah. It makes it so hard to navigate. It's so tricky and hard to know, is somebody experiencing a health condition that we need to intervene, or are they so nervous and then it's, experiencing these symptoms? And I often think about the idea that no matter what the health condition is, people of all sizes do experience that health condition. So why not treat everybody with the interventions we would use for thinner folks, to address that health concern, that's something that's available and that we can try without worrying about trying to alter somebody's weight.
Right, right. It's not the messaging that they're getting from the world, just like
Right.
every other issue around
Yeah.
body image, right? It's really
It's
hard.
So, it's so hard. It really feels like an uphill battle a lot. Yeah.
Sure
thanks.
does. Thank you.
Thank you.
I was going to also echo that. I think that in clients, there's definitely a fear that is an anxiety around health that is brought on by the culture and certainly medicine. The medical community really obsessed with BMI, and then really taking correlation maybe in certain instances with causation and trying to tease that out, with the client. So it's very difficult for the client to trust information that's out there. But I also think in the mental health setting, with practitioners, I think it's very easy to miss the diagnosis because there are assumptions made based upon body size.
Yes.
And so you have to be, I think, very mindful about asking the right questions and understanding that, a person who lives in a larger body can have a very serious eating disorder, instead instead of making, an assumption that they cannot. So,
Absolutely. Yeah, like whether or not even somebody's going to get access to that eating disorder diagnosis depends a lot on whether their providers think that you have to be particularly thin to be diagnosed with an eating disorder. And we do know that higher weight folks are very delayed in getting eating disorder care. It's so often conceptualized as, oh, they have a weight problem versus, oh, they have an eating disorder. Yeah, something just happened in our clinic last week that will make your blood boil. I'm still mad about it, but basically one of our higher weight eating disorder patients with atypical anorexia was getting we call them DDS evaluations, like their disability service evaluations. And the psychologist that was evaluating her asked her if she's receiving any mental health care anywhere. And she shared, yeah, I'm at the eating disorder training clinic. And he's like, why would you be there? And she said, for my eating disorder. And he goes, what, you have an eating disorder? What eating disorder? And, she said, and she's very knowledgeable about her diagnosis. And she said, I have atypical anorexia. And he literally paused and looked her up and down, looked at her body and said, you don't look like you have an eating disorder. So it's so unfortunate, and it just breaks my heart how often we hear these stories from our patients of them just trying to advocate for themselves and do their best in addressing health, and then coming up to barrier, and often also being harmed in the process.
Yeah, I was just thinking about the first reflected questions you put on the slides and the silence. And I think it just made me think about to what extent we can acknowledge, as clinicians, acknowledge our biases and how much that affect us and our own comfort level to bring up this topic with the patient. And also thinking on the patient side, well, it's also affecting them to access care or talk about this topic with the patient, especially for many people who may have already had bad experiences with their healthcare provider. Like it looks like this issue can often get ignored for long periods of time.
Yeah, that's a great point, that even those of us that want to talk about it more with patients or make sure we're addressing it, we have to do our own personal work and work through biases. And so many of us hold these biases, and it's not easy to work through them. We don't always have the tools or don't know what the next steps are. So you're right, that's such an important part of the process. Yeah. Thank you. Yeah. Next slide, please. And folks, if anyone has anything else to add at any point, just feel free to chime in. I just listed some ways that I was thinking about, it comes up, and some of you all have highlighted some of these, like obviously in the eating disorder field, like missing those cases, right? You all have noted that, really important. And like the piece around the recommendations, I often see people with atypical anorexia that are higher weight being, even though they need to gain weight, just like people with anorexia nervosa, that their meal plans aren't supportive of weight gain and that they're prescribed an entire different meal plan. So I worry about that a lot. Even though we know from the research that atypical anorexia is just as impairing as anorexia, both in terms of like mental health, eating disorder specific psychopathology, and physical health. We also see that, like you mentioned with the biases that we hold, clinicians tend to have a lot of like unrecognized biases that impact their expectations of whether or not patients will be able to reach their treatment goals. So that's another area I worry a lot about if we don't kind of work in this area and do our own personal work. People, different types of clinicians often say, that they would rate somebody with higher weight as being less likely to be compliant, to do homework, to meet those goals. And obviously, like our own expectations of our patients, they see that, they feel that, and us holding hope for them and believing in them is so essential for their progress. You might see, judgments towards higher weight colleagues and patients. I see just even in my workplace, sometimes I hear people be like, oh no, you brought donuts today. Like I shouldn't, that's not good. Like people have a lot of like guilt and shame around certain foods, and obviously straight up commenting on people's body shapes and size are ways it can show up. Not having like appropriate seating. I also worry about things like images of health. Like how often do we see like a very thin white woman eating an apple next to like some sort of declaration of health, that we group those things and associate those things. And then obviously like recommending people to weight loss without figuring out whether a different approach might be better, or is there another way we can meet their goals without actually intentionally changing their weight. Next slide. So I wanted to kind of give some folks some ideas for some size inclusive practice. I know this is such a short time to meet, so we can't do a ton together, but I put a bunch of ideas in here, and then like if any of them are of interest to folks, I'm always happy to follow up. But I wanted to give people like a start of places to look, because we, ultimately, we really, that one thing we can do is just make our personal practice a place that's weight and size inclusive, that's supportive of people reaching their health goals, whatever those are, without changing weight. There's lots of ways to address health. So I have a couple ideas for y'all. Next slide, please. All right. So, and I wanted to kind of just highlight like what's the difference between a weight-centric approach and a weight-inclusive approach. So one example I see pretty much weekly is that people get recommended weight loss when they experience knee pain. But my lovely colleagues in PT that are in my same building, they had shared with me the literature on knee pain. And the big reason for knee pain is when you don't have good hip strength. It's obviously much more complicated than I'm saying because I'm not a physical therapist, but I just want to note that a more weight inclusive way to address knee pain would be to address the issue that's contributing to it most, which is likely hip strength, hip flexors, rather than just like a blanket recommendation for weight loss. Another common one I see is people feeling badly about their bodies and telling their clinicians, I want to lose weight, I don't feel good or comfortable in this body. So a weight-centric approach would support them in losing weight. A weight-inclusive approach would be, first of all, to assess whether or not this is coming from some other place. Like maybe they've internalized weight stigma, maybe there's body image concerns. People have all sorts of reasons they want to lose weight. And it's not it's not my place to tell people that they shouldn't, or to judge people if they pursue it. But it is my place to be able to explore if maybe there's other ways that we can meet their needs without intentionally pursuing weight loss. So often with my patients, they've internalized weight stigma. They feel really bad about themselves, and we could tackle it via reducing their body image concerns and internalized weight stigma. It is a tough process though. So that is definitely a challenge, but one that can be really rewarding and longstanding. The other piece that I'll mention is it can be really tricky when something like weight stigma is something that is related to experiencing discrimination, including violence, being paid less at work, being able to have fewer options and resources and navigating the world. So ultimately, if somebody chooses that weight loss is what they feel is best after being informed, then, I would definitely not judge that. People need to do what they need to do. I think about this, like, when I worked with a lot of trans folks at the VA, and some of them that lived in really rural regions where, their entire support system would not be supportive of their most authentic, true identity. Some of them did decide through therapy that, they wouldn't pursue gender affirming care because they couldn't afford to lose their entire social support system, be kicked out of the church, things that were meaningful to them. Like, everyone kind of has a different hierarchy of what's most important to them. And as much as I wish everyone could live most authentically, that's, people have other realities. So I just want to acknowledge that complicating piece. Another really common weight-centric one is like weight loss and exercise being tied together, like, oh, burn calories, lose weight. When I see exercise as, that's a really lovely research-supported approach to health, whether or not people change weight. So why not find ways that people can relate to exercise, if they choose, in a joyful way that feels really compatible with goals and values? So for example, maybe they want to meet new friends, a Zumba class might be a good fit. Or maybe they want to feel accomplished, so something where you have to kind of like keep working at it, to achieve something might be a good fit. And thinking about what are they trying to get out of this, like maybe improved sleep or stress management. Next slide, please. I give a little example of a sheet I do with people all the time of like, what are your values? What are your interests? What are your priorities? And they note like, okay, I wanna have fun, and I wanna, do a structured activity, so like the Zumba example I gave might be a really good fit for that. Like trying to match what their priorities are to activities, rather than like, oh, I'm gonna go on that elliptical and watch the screen about how many calories I burned. Like that is such a different relationship with exercise. So really kind of trying to shift it from being about physical activity and more joyful movement. And people of all sizes deserve to have access to that. And that it can be fully separated and nothing to do and no goal related to losing weight from it. Next slide, please. Other shifts would be obviously like if they're focused on any level of like appearance, that you think about what are the functions of body parts. This is such a silly example, but I'm going to give it only because one time I met someone and like 6 months later, they're like, I was thinking about that thing you said, and that, I just like everyone else, I'm in my own journey on how I think about my body. And an area that has always been a challenge for me is my thighs. But I noticed one day that, oh my gosh, like my dogs always sit on my lap and not my spouse's lap, who has much smaller thighs. And I was like, oh my gosh, like what a thing I can appreciate, that because of my body, the thing that I felt insecure about, I actually have this like extra gift and this extra benefit. So kind of a silly example, but like what are functions that we're not thinking about that are important related to our bodies? Another really big one is like curating social media, right? Like you'd shared in here about the idea of, what you're viewing is impacting, makes a ton of sense. But is it realistic that we're all never going to go on social media again? Probably not. Those of us that work with teens, definitely not. So why not like curate it to be a place where you're seeing like maybe fat liberation posts and just seeing some other perspectives, so it's not like a bunch of what I eat in a day videos or, things that are reinforcing weight stigma. Identifying values is a great one. Usually when I ask patients if on their deathbed they want to be reflecting and really glad that they spent all those years trying to change their bodies, like they're all like, no, I would never want that. I'm like, well, what is meaningful to you? Like, so if any of you do values work with patients, like this is a really good area that you could tie to, reducing their internalized stigma or their focus on weight or body. Obviously, if you're doing, I am a huge fan of CBT, but you have to be careful with certain things. Like you have to be careful of inadvertently like invalidating the valid. Like maybe they're not just afraid they might be treated poorly or that people will talk badly about them, but people do that. So I think, that's just something to kind of keep your eye on. Regular eating's a great thing for folks, like because the second you start kind of skipping and moving around with your eating, you're reinforcing that weight's important. Changing attitudes around good or bad food, healthy or unhealthy, but seeing that all foods have their utility. Like, sure, a cupcake is not super nutrient dense, like I'll own that, but like, who doesn't love to like have a nice celebration with your loved ones? Like, there's something really joyful in that. Joy is part of our health. Joy is part of our well-being. Flexibility is part of our well-being. So kind of thinking of like getting creative with ways that people can see different sides of things that they've put in a bad category. It doesn't mean that all of a sudden they're only going to eat cupcakes, right? That's not what it just means that, that food's actually not that interested anymore. It's used whenever it makes sense. Other foods are used in other circumstances, and that's a great thing. I also think it's important to just kind of acknowledge like that people might have a lot of shame, that it is difficult navigating the world in a higher weight. Not because of the higher weight, but because of how the world is set up and for how people might treat you. And that is so fair and valid, and we don't want to ever deny that for folks. Obviously, things like, some of the classic ED things like not calorie tracking or weighing food can be really useful here. And then kind of reducing weighing oneself and not having that in relation to movement or eating. So those are some like, just general ways I try to infuse that. I also might explicitly teach people about weight stigma, which means that if it's an area you haven't spent a lot of time in, you want to get more comfortable with describing what weight stigma is, how it might be impacting your patient, where it comes from. Any of your patients that, do care about some social justice, they might really attach to this and feel like, oh, okay, that's another area where, some folks are marginalized. And when they see it that way, it's like a different way to relate to it. And then you could get mad at the system versus internally hating oneself. Next slide. I also put on here, most of these are like, communities that you could join or like get more information. But we do know that some really positive health outcome some, ways that people could have more positive health would be changes in eating and physical activity are great, but think about the rationale for them, not for weight, but because everybody deserves to have food in moderation. Like having nothing but cupcakes or having nothing but carrots are like not useful. Like that's not good for anyone. So, trying to kind of have people just of all sizes see that all food's fine. And that physical activity can be that, that joyful, mindful movement type of way. Going to healthcare. So maybe you might have to help your patient advocate for themselves. I unfortunately call physicians about once a week to talk to them about something offensive they said to one of my patients. But a lot of times it's like gearing them up, maybe doing a role play of how might you bring this up to your provider, and what will you do if and when they tell you to lose weight or reinforce something negative that you're working really hard to overcome. So planning for that and being kind of aware that that's likely to happen. I just referred my patient to somebody who I had a great experience with, but I'm not higher weight. And this provider was totally mean to my patient. So unfortunately, we can't always know. So we want to have people prepared for that possibility. Eating competence, like feeling like one knows when to eat, how to eat, the flexibility with all of that, like kind of just general knowledge around eating can be helpful. Obviously, reducing stigma is key here. Food insecurity is a big one. It can be really helpful to refer people to somewhere that might be helpful, they could access some food, and how to plan out if they tend to have a restrict binge cycle related to food insecurity. And then obviously folks might know of like Health at Every Size community and intuitive eating communities. Just a reminder that intuitive eating is not just listening to hunger fullness cues, but it is rejecting diet mentality. There's a lot of other components that can be really useful for patients. and getting good sleep, stress management, like these are all excellent predictors of health. And none of these things have to do with changing someone's weight. Next slide, please. I have a bunch of, well, several slides on here about like ways that people might challenge weight stigma, both personally and institutionally. So, I'm happy to share these slides with folks if folks want to look these over later, because I know we don't have much time to tackle it too much. And I have some lists of like books that I like and podcasts and online resources where people can do some further info. But I want to check and see if folks have any questions or things that they kind of grapple with or responses.
Yeah, I was just curious how you deal with client who is, may have stopped binging, for example, is practicing, is understanding and practicing more in a more intuitive eating, but is really struggling with the idea of acceptance of
Yeah.
potentially living in a larger body.
Yeah.
Because what I've noticed is, unfortunately, with a restrictive yo-yo pattern over a long time, the body is just almost stuck at
Mm.
that, you know, at a larger body size, because it almost seems like it's just tripped up because it was starving itself so much that the body is like almost like it seems like clinging to staying at that higher body size. But it's just, given everything you just said, the weight stigma and living in a society that is so harsh and cruel to people in larger bodies, I think is a lot for a person to take.
Yeah, absolutely. No, thanks for that question. That's an excellent question. I noticed that a lot in my practice too, that is like, that's probably one of the biggest challenges that patients have is they did a great job behaviorally, they're moving forward, but they're really stuck in this acceptance piece. Like, how do they actually accept? And how do they accept the idea that maybe higher weight is their recovered body and that that's the only place that they can have recovery? Because I think that's the big piece is if you eat regularly and you do a moderate amount of exercise and you do general health recommendations and you're higher weight, that's probably because that's where your body wants to be. And I often encourage folks to not see their weight as like a stagnant thing, but that over time as life occurs, that there's going to be some transitions that happen, that the weight that their body needed at one point might be a totally different weight at a different point. And their weight that their body might need for recovery might just not look like what they ever expected for themselves. So what do they need to accept that? Like what kind of things do they worry about with accepting it? And for some people, they mentioned they worry about health. So it could be really great to do that psychoed of like, actually, you could have awesome health. You can do all these great things that research supports as being predictive of health without your weight. And often when you interrogate that a little bit, you find it's not about health at all. Because I ask people directly, like, if you knew you weren't going to lose weight at all, would you care? And they're like, no, I only want, it's because I want to lose weight. And I'm like, yep, it's not about health, especially if you're not doing healthy behaviors, right? If you're doing eating disorder behaviors, you don't care about health. Like, it's not about health. So kind of like pointing some of that out could be helpful. For other people, it's like, I'm actually being treated poorly, like, so you might kind of work with them and see if some of their loved ones, if they can navigate some of those situations. Maybe they can, maybe they can't, but worth a try, because we, maybe some interpersonal effectiveness of requesting folks to not comment on their bodies, or having some folks that they know are like safe folks to talk, they won't experience any weight stigma for them. Maybe they've outgrown some of their support people. But I think kind of understanding like what they're worried about with accepting will give you a lot of insight into what do you need to tackle then, because there's so many reasons they might have a hard time accepting. And explicitly teaching about weight stigma.
Thank you.
Yeah, thanks for that
Would
question.
love to get any resources that especially psychoeducation on weight stigma and explicit teaching of weight stigma would be really helpful. Really appreciate it.
Absolutely, yeah. I can send stuff over so that those can be distributed.
I do have a quick question.
Yeah.
So I'm just curious, like, what have you found to be helpful to communicate this issue with physicians, other healthcare providers? Like, what works, what doesn't work?
Yeah, no, that's a great question. I would start with your shared value of supporting the patient's well-being. Like I would just like actually explicitly note that. Like, hey, we're both working with so and so, and I know we both really want them to meet their health goals, which are X, Y, and Z. And I would mention to them, like, "Hey, I noticed that one thing that they're really struggling with is they've been internalizing a lot of weight stigma. And you might need to explain what that is, but kind of just sharing that this is what they're dealing with. And you're worried about that because of the association of stigma and adverse health outcomes. So you worry that it's going to actually make them less likely to meet those goals. And if you notice the provider's doing something unhelpful, maybe you just kind of note like, one thing I was thinking that might be really good with when you meet with this patient is to ask them if they feel comfortable being weighed today or if they'd rather skip it today. Like kind of giving them options or whatever it is that you want to like make the request of what you'd like to see different. Some providers are totally on board and they're like, oh my gosh, I didn't know that. Thanks for sharing it. A lot of them are pretty defensive. So in terms of that, I just try to do like a validate, like you're on the same team. You're not telling them that they're wrong. You're just explaining what your patient needs. And ultimately, often people will at least agree to whatever you're asking, even if it's for a short time period. Like I had one provider be like, fine, I won't recommend weight loss for them for 6 weeks. And I'm like, okay, I guess I'll just treat their eating disorder in 6 weeks. But so sometimes it's like a negotiation. And when they see people are doing better with reaching their health goals with a size inclusive approach, they tend to buy in more. Yeah, thanks for that question. Well, I'll definitely send folks, I'll send this to Dr. Boswell and she can share with folks slides or any other materials I have if that works okay.
Yeah, that sounds great. Thank you so much for the, really illuminating and insightful talk. I can tell that, folks really appreciated it. It was such an engaging and important topic. So thank you so much.
Of course. Thanks so much for having me and thank you all for caring about this topic.
Yeah, what a nice way to start off our didactic series with like something that cuts across all like healthcare locations and is useful for all providers. So we're really grateful for your time.
Thank you so much. It's great meeting you all.
Thank you.
Thanks so much.